I'd just like to give a little bit of context, really, just with regards to Sheffield Chamber's role on the COVID outbreak board, which is how we've been fortunate enough to ask Greg to come and speak to us today. So you may be aware that all local authorities have been advised that they need to form a COVID outbreak board, and Sheffield Chamber are representing our members and our premium partners and our patrons on that board, so that if we have information we need to quickly get out to the business community, then we're able to do that. So I just wanted to make people aware that that was something that Sheffield Chamber were doing. They're also part of the business response group, which has been formed with Sheffield City Council to help formulate an economic recovery plan and have the opportunity to have business community feed into that. So I would like to welcome Greg this afternoon. I'm very grateful to you for coming and speaking to us this afternoon. I know you're very busy with very important things to be getting on with. So we're very fortunate to have you here this afternoon. For those of you that don't know, Greg is the Director of Public Health for Sheffield. I'm going to ask him to just tell us a little bit about his journey to that post. For those of you that follow Greg on Twitter, you, like me, have probably been very grateful for his very informative and sensible updates that we've been receiving in light of some of the mixed messages that we've been receiving from other sources. It's been really, I found it very sobering to have somebody explaining the situation as it is, but with common sense and in a very reassuring tone. So I'm very grateful to Greg for that. We're going to have the opportunity to hear some COVID specific information and have some Q&A about that, and then some more general public health information and some Q&A about that. So I think that's everything from me. So if I can just ask Greg to just tell us a little bit about you, and then we'll move to the slides. Thanks.
Okay. Greg. Thanks, Lou. So hi, thanks for coming. My name is Greg Fell, as Lou said. I'm Director of Public Health. I usually hang around at the Town Hall, but I've not actually been at the Town Hall for about the last 14 weeks, so I've kind of forgotten what it looks like. I've been at home, and it's been, well, I'm sick of being at home, to be honest, so I'll try and make COVID over as soon as humanly possible so we can all get back to normal. Anyway, Lou asked me to talk about me. So many years ago, I did a degree in biochemistry and molecular biology, and in the final term of a 3-year degree in biochemistry and molecular biology, I decided that I didn't want to be a biochemist, nor a molecular biologist, nor did I want to work in a lab, nor did I want to work for a pharma company, nor did I want to be a science teacher. Right, what do you do now? So by hook and crook, ended up as a researcher in Hull Medical School, doing a whole bunch of pieces of research, and then ended up in a public health job in what were then health authorities. For those of you that are long in the tooth, that was about 7 NHS reorganisations ago, and worked my way through a career in various roles in public health till eventually I landed in Sheffield as Director of Public Health in 2016, where I've been ever since. It's a fab job and I enjoy it thoroughly. I'll talk a little bit about the broader role after I've done the sort of the COVID specific stuff, because clearly that's the thing of the moment, and I'm certainly having to work for my living at the moment. So I'll talk a wee bit about the COVID stuff. I've got some slides, and hopefully, I mean, circulate the slides by all means. There's only 10 of them. Circulate them. They're just a bit of background and a kind of talking point. So if I talk for about, I don't know, 10 or 15 minutes to those slides, and then basically open floor, go anywhere you want with any questions. You can't possibly think of a question that hasn't been asked somewhere, and I've lost count of the number of questions I've had. So, you know, go anywhere you want with the questions, the ones that you think are plain crazy, or even the ones that you think are sensible. So should we kick off with the slides? That's the end slide. That's where I worry. That's the ones I worry about. So let's start. Simple slide: COVID prevention and management. And the only thing I'll say about the slide is prevention. We're focusing on prevention as well as managing. You know, clearly we have incidents to manage. They're managed pretty well, but prevention is the thing of the moment. So I'll start with epidemiology. One of the few joys of COVID-19 is I no longer have to explain what epidemiology is. which is a good thing. But basically, it's the kind of how many people are poorly with what and where are they. So this is a week, it's a week old now, and it's changed ever so slightly since then. But basically, if you look at a map of England, the Northwest and Yorkshire stand out as having slightly higher rates than the rest of England. The exceptions to that are Herefordshire, which is the red dot on the left-hand side of the screen on the Welsh borders as I look at it. There's a giant workplace outbreak going on there in a farm or agricultural setup. I can't quite remember the specifics of that one. And Leicester, which is well trod, been all over the press, which is the red dot right in the middle of the map. So those are the exceptions. Then if you look at the rest of the map, what stands out is it's the heavily densely populated towns of the northwest and Yorkshire and Humber. Sheffield and South Yorkshire more broadly do stand out nationally. And one of the things that's proving somewhat troublesome is that whilst we're well over the first wave of the epidemic, well over the first wave of the epidemic, the numbers in Sheffield and actually South Yorkshire are just a little bit too high for comfort and are proving quite stubborn. And that's attracted us some national attention from various cabinet ministers, but particularly Matt Hancock, but also others. And I'll pick up on that as we go. So the numbers don't lie. Whilst the shape of the epidemic curve is going in the right direction, and to all intents and purposes, wave one is over. It's not all over, and there's very much potential for waves 1 and 2. So click on to the next slide. So this is Sheffield data, and this is the number of people who have tested positive since February actually, up right till now. So currently there are in the order, it varies a bit day to day, but there are in the order of about 8 to 10 people that test positive per day in Sheffield, so in population of 560,000. So not many, but and it's an important but, that number accumulates day after day after day after day. And as I say, it's proving a little bit stubborn. You can see the shape of the curve yourself. Started really slowly, so I began to be worried in January, just about New Year time, when we heard about events in Wuhan in China. Immediately you read the World Health Organization bulletins and you think, oh shit. It was clear that this was going to be worldwide spread. There was no doubt about that. So folk like me Twittered a lot. So I literally Twittered, but I also Twittered quite a lot between January and February. But it didn't really take off in the public consciousness till we started having domestic cases in late February, early March, and then you can see how quickly that took off. So it's tailed off significantly, and we're nowhere near where we were at the peak of this, nowhere near. And actually, I think it's fair to say that through all of this, we got nowhere near the worst case scenario. When it was a realistic worst case scenario, was 500,000 people dying, 500,000 people dying in wave one. We got to about, depending on which data source you believe, somewhere between 50 and 60,000. And I won't get into the technicalities of how you do the counting because it's awful. So we got nowhere near the worst case scenario. We got nowhere near what happened in Wuhan, Lombardy in Italy, and all sorts of other places where intensive care units were overrun and people died because they couldn't get into intensive care. We got nowhere near that. A lot of people did die, all up 400 people or so in Sheffield, and we know that there will be a significant long-term impact of the people who had severe infection, far worse, hugely worse than flu. For reasons that no one quite understands the biology yet. So it will have a lasting impact, no doubt about that. But we never got near the worst case scenarios. And the reason we didn't was because we did do a lockdown. The inquiry will doubtless conclude that we did the lockdown about 3 weeks too late. But we did do the lockdown. The big however is that whilst numbers now are quite low, not as low as I want them to be, and I want them to come down further, and I'll explain that in a minute, 5% of the population were exposed in wave one, thus 95% of the population are still susceptible. So all of the conditions of wave 2, 3, 4, 5, and 6 are still present. You look at what the virologists are saying, and what the immunology is saying is that whilst there's a lot of hope for a vaccine, and Deputy Chief Medical Officer is of the view that it's possible a vaccine will be ready this year, I'm not betting on it. I think a vaccine will be ready and widely available by the middle of next calendar year. And actually, we genuinely don't know about the immune response. There's two schools of thought. One school of thought is that the immune response is long-lived. The other one is that it's short-lived. If it's short-lived, that has massive implications for vaccine efficacy. So what you read what the virologists are saying is that we will basically get immune to COVID-19 over a period of 5 to 10 years, and it will take that long. So don't think that this is anywhere near over. It isn't. It has a long way to run yet. That said, we're in a reasonably good, reasonably comfortable position, and quite rightly, we're kind of working out how we unpick the lockdown, which will be much harder than kind of doing the lockdown in the first place. And we all know, you know better than me, there will be long-term economic impacts of this. So yeah, we've got to manage that. So go on, next slide. I'm droning on a bit too much. Sorry. Oh, I've lost the slide share. Never worked with children, live animals, or internet connections. Just to get to who's being affected, this is a really quick slide, but basically I'd look at the left-hand side of the slide. The right-hand side of the slide is the last 7 days. The left-hand side of the slide is the age distribution of who's been tested positive over the course of the pandemic from 1st of March up until middle of July. Overwhelmingly working age people. So overwhelmingly those that have ended up sadly dying or in intensive care is the very old, the very frail, and the very infirm. But the number of people who are affected is principally working age people. And whilst you see that, I suppose one of the side points of the slide is whilst you see in the media wall-to-wall pictures of intensive care units, the reality is that the vast majority of us who have this illness, all up 5% of us thus far, will have had really mild symptoms. In fact, many of us might have had symptoms so mild we didn't even notice. And there's an important message in there. That's fine for me, but it might not be fine for my gran or my wife who has who's compromised immune system. It is important that we kind of make sure that we kind of obey the rules, put bluntly, and get tested when we've got symptoms. The message is that those are affected are principally working age population. And we don't know a great deal about kids, actually. We're not testing kids that much because kids have symptoms so mild. As a rule, kids have symptoms so mild that no one even thinks to test them. So actually the bottom end of both of those charts is a reflection of who's been tested rather than who's actually got the illness. The other thing it's fair to say is that of 100 people who have this illness, only between 20 and 30 of them will actually get a test. And the vast majority of those who get a test are actually negative tests, not positive tests. So there's a sort of a hidden iceberg that we don't know a great deal about. So the Office of National Statistics do weekly epidemiology surveys, and that's a consistent finding. So we kind of diagnose about 20 to 30% of the true illness that's out there. So go on, keep going. Next slide. It's fun. This I can't remember what I wrote in these slides. It's exciting to see what comes up next.
I am sorry.
Oh no!
The screen share always crashes on Zoom, so sorry.
Would it help if I did a screen share? Was that?
It might be worth trying after. We'll try one more time, but it does always crash when you're sharing.
Test. I'll be quick on this slide. So test and trace. So we have a contact tracing service established. We had a contact tracing service established in the very early stages of the pandemic. was known as the contain phase, and Public Health England did that contact tracing quite heroically. Actually, they delayed the large uptick in the spike by at least a month by what they were doing. Eventually, basically, it got overwhelmed. Contact tracing, for anybody who's ever done it, it's a hugely labour-intensive business because you got to phone 20 or 30 people per case to work out where they've been, to have a conversation with them, to tell them they need to be at home, and maybe to get them a test. The PHE gave up in the early stages of the pandemic because we didn't have enough testing capacity. There wasn't enough lab capacity in the country to test the number of cases, and there wasn't enough skilled humans to do it. So it was abandoned for those reasons. And government had, and this isn't a party political point, it's a statement of fact, government had eroded the capacity of public health to respond to these kinds of things over a decade. So we quickly ran out of human capacity at the end. So simple as that. We have invested significantly in this since, and there is a service operation. It's called the NHS Test and Trace Service, and it basically does contact tracing. It's a combination of national, regional, and local effort. And the key chart is this one. It gives you a sense of the number of cases. This is Sheffield data. A number of cases who are identified to test and trace, which is everybody who tests positive per day since May. This one goes. So it's the far right of the chart, which is the interesting bit. Just gives you a sense of the volume of people per day. So it's pretty low. Long may that remain, and we've got pretty good arrangements for keeping it low. But it's a really important but. As we unpick the lockdown, more humans will interact with each other. That's what humans do. And the more interaction there is, the more opportunity there is for spread of the virus. And we have all seen what exponential growth does now. Perfectly apparent in late February, early March. You saw what exponential growth does. You saw where that takes us. No one wants to go back there. So it becomes critically important that stuff like this continues to work and we keep a handle on it. But equally, test and trace kind of only works in a context. Stuff like washing your hands matters a lot. Stuff like staying at home if you've got symptoms matters a lot. Those are the things that also make a difference to avoiding a second unmitigated wave of the pandemic and a lockdown that may follow, which will be equally damaging to the first one. So important point. Watch the test and trace data, and I'll kind of try and keep you. Well, I'll certainly keep Louise updated on that one, and she may well pass that on. So go on, keep going, and we'll see whether we crash the screen again. No, we don't. This is how we do regionally. This is the same data as you saw in the last slide, but in a line chart and regionally. Sheffield is the blue dotty line in the middle of the screen that you can see. Sheffield's about average and coming down, unlike some parts of the region. Some parts of the region really, really are on the worry list. Sheffield was briefly on the worry list, but wrongly so. And the numbers are coming down, but as I say, they're a bit stubborn. So keep going. I've talked enough about data, I think. There you go. So epidemiology summary. Transmission of infection is driven by households. You look at the data, we've moved away from where there's massive transmission across large communities, and you can see the hotspots in mainly but not exclusively the east of Sheffield, and it's households, it's big homes, multiple occupation households. The infection is principally in working age people. The importance of working age people knowing the rules, knowing the guidelines is there. As I say, there is a pretty strong geographic pattern to that one. If you look at the map, I didn't show it, but if you look at the map of Sheffield, where we're really focusing our efforts is on the 5 or 6 wards to the east of the city centre, from Darnell, Handsworth in the south, right the way through to Jordanthorpe, Upperthorpe, to the north of the city centre. That's where we're really focusing our effort. It's a stable number and rate, but it's a higher rate than comfortable. And as I say, what we're pushing to avoid is that rate going up. What we are nowhere near Leicester. Everyone says, well, when will we be locking down? No, we won't be locking down. And then everyone says, what does lockdown mean? I'll come on to that in a minute. But we're nowhere near locking down. So the rates in Sheffield are in the order, seven-day incidence rates is in the order of between 11 and 12 per 100,000 per week. Leicester at its peak was 180 per 100,000 per week. So you're much higher and going up. Leicester's now coming down. We are much lower level and coming down, but it's stubborn. As I say, we've seen what exponential growth does. We've seen that this can get out of hand quickly. So we can't, and I'm not going to ignore it. And we've shifted our strategy to focus on the east of the city. We're not going to neglect the rest of the city, but where we know we need to focus on is on the east of the city, and we're addressing that very, very directly. So then on to next slide, and we'll go on to what we're doing about it. So the strategy, four aims to the strategy, and there's those 4 top bullet points: keep people safe, protect the vulnerable, and by the vulnerable I mean those that have been shielding, and the very, very elderly, because they're more at risk of very, very severe illness than me. Or most of you on the call, I'm sure. Reopen Sheffield and follow government advice. And the follow government advice is 4th on that list for a reason, because as Lou has intimated, sometimes government advice is a bit inconsistent or a bit sketchy or a bit patchy. So I'm reading the government advice this morning on reopening places of worship. I've got halfway through it. I found about 17 significant inconsistencies. Which I'm going to end up having to write something myself. And I'm over guidance. I'm at peak guidance now. I've lost count of the amount of bloody guidance I've read. I'm way over peak guidance, and a lot of it is inconsistent, and a lot of it actually doesn't work that well. So that's the reason why the follow government advice is at the bottom of the list. So that's basically the strategy. So other things to note. Keeping transmission is really, really important, fundamentally important to reopen the economy. If you ever wanted an exposition as to why health matters to the economy and the economy matters to health, there it is in a nutshell. You've seen it, you're living it, and it's a two-way thing. That relationship matters in both directions. So we've got to get it right. Because the last thing that anyone wants is anything akin to a lockdown or going back to where we have been in the last few months. It would be really bad for that to happen, but it could happen. All of the preconditions are there. It could happen. So it's up to all of us to try and avoid that happening. As I say, we're pushing the numbers to get them as low as possible. 0 is impossible. I don't think we're not going to get to 0. There's going to be there's going to be a rate which is just a background rate of COVID-19 infection that bubbles along in the background, just as there's always cold. Coronavirus, COVID is a coronavirus, common cold is a coronavirus. So there's always going to be a background rate. So the onus is on us to get it as low as possible. As I say, we're focusing on communities with the highest rates of transmission, and we're very, very much focusing on enhancing our testing strategy, doing that street by street, neighbourhood by neighbourhood. We've got people, I don't know if we've got people out today, but we have had people out door knocking, and really focusing on households where we know we've had multiple cases in the last 28 days, because that's where the infections will spread out from. So we're kind of focusing on that very, very directly at source. The one thing I will say is that I'm really mindful that this is concentrated in the east of Sheffield, where most but not all of the Asian population is. I'm exceptionally mindful of social cohesion issues that I've seen what's happened in other parts of Yorkshire. The far right have picked up on this and are playing the games that the far right often play. So it's really, really important to be clear on that one. This isn't an Asian thing or something that's the fault of the Asian population. And it's an important message to get out. So we have a plan. There's always a plan. It's not terribly long. But this was one of the facets of the shift in government strategy about a month ago, was to ask local authorities to be responsible for a plan, so that it's not only a government Whitehall-led response. So we have a plan. The link to it's at the bottom of the slide. If you have trouble sleeping, link to it's at the bottom of the slide. They're set up around a number of themes: surveillance and early warning. You've heard me drone on a lot about the data. Incident management, which is about outbreak control, narrowly defined. We have incidents, we've had them, we're going to have more of them, and we've got the right arrangements for managing those pretty quickly. Focus on vulnerable groups. Focus, and then that's the shielding cohort. Focus on prevention, which is principally comms, wash your hands, etc. Face coverings. I might come on to face coverings in the questions, yeah. But that kind of stuff. Test, trace, and isolate. Contact tracing in old money. So public health professionals have always called it contact tracing, but government have chosen to call it something else now. Which is if I develop symptoms, I will be called by the test and trace service, and I will be asked where I've been, who I've been in contact with. They will be called. That's what that is, and it's time-honoured tradition of getting on top of incidents of communicable disease or infectious disease. And then settings, focus on settings. Schools, incidents in workplaces, care homes will be. Care homes is largely under control now, but it will become much more problematic in autumn into winter. So, isolated, closed settings where we've got relatively closed populations. So keep going slides wise. There's a management board. It was initially called the Outbreak Control Board, chaired by the leader of the council. That gives you a sense of the sort of the gravitas with which we stick on it. As I say, it was called the Outbreak Control Board, but Julie decided she wanted to call it, let me get this right, the Coronavirus Prevention and Management Board. Trips off the tongue, doesn't it? And doubtless we'll have a 3-letter acronym to put on it at some point in the near future. I hope so. So it's not a city. So the leader of the council chairs it, but Julie's really clear. It's not a city council thing. It's a city thing. It's a city leadership thing. And again, Julie was also really clear. She didn't want it to be sort of the chair of Sheffield Teaching Hospitals, with the greatest respect to the chair of Sheffield Teaching Hospitals, or the vice chancellor of the university. She wanted to get into the guts of how a whole bunch of different communities, constituencies, groups of people think and behave. So we've got representation from Disability Sheffield, representing the interests of those with a disability. We've got representatives from the faith community. Lou is a representative of the business community. So we're really trying, not perfectly, but we're trying to get into how different groups of people, cohorts of people and constituencies think and act. Reach and understanding is really important. And Julie's 3 monikers: prevent, know, and respond. So, prevention goes without saying. Knowing is early warning, surveillance, all that kind of stuff. And respond, if we have something, we respond. We get boots on the ground quickly and deploy those boots according to whatever the circumstance of the day is, to give the city confidence that it can safely reopen and we can keep the level of virus low and respond to incidents as they happen. So, of course, it has to ensure some progress on some oversight of the plan itself. And then I won't dwell on it now, but there's a whole bunch of operational arrangements that deal with the implementation of the plan in a whole bunch of other groups. So, most of my team are doing nothing else but this now and won't be doing for the foreseeable future. So, we've got fairly intense focus on this, and will be for quite a long time. It's going quite how we do the rest of the public health stuff, I don't know, but we'll cross that bridge in a bit. So keep going. I think I'm nearly done. Worry list is not all over. Anyone who thinks that numbers are low, it's all over. It's not all over. There are 3 scenarios. One, it could go away. And there's precedent for that with coronaviruses. They just disappear for reasons that no one really understands. Chief Medical Officer thinks that's unlikely. I think it's unlikely. 2, that we burble along with a fairly low background rate for the foreseeable future. Probably the most likely scenario. 3 is where scenario 2 goes wrong and there's a 2nd, 3rd and 4th unmitigated wave. So whichever of the two scenarios 2 and 3 comes to pass, we need to keep it 2, not 3. There will be incidents. I can think of 5 incidents that are going on at the moment. They're being appropriately managed. They're never quite in control. You can't control these things because there's 75 moving pieces and you only know what half of them are, and never mind can you control them. But they're being well managed. We've had a few significant workplace outbreaks actually, and to their credit, the owners of the businesses concerned absolutely did the right thing. In the right way at the right time. But there'll be more incidents, there's no doubts about that. So other things on my worry list: people with symptoms not getting tested. If I get this, I hope I'll have really mild illness, can I really be bothered to get tested? Because if I get tested and it turns positive, someone's going to tell me I've got to be at home for 3 weeks or 2 weeks. Sorry, 2 weeks. There'll be a bunch of people with really mild symptoms that won't get tested. That's great for them because they'll just have symptoms akin to a common cold for a fortnight, but it might not be good for who they transmit it to. 50% of people don't isolate, and that stopped me dead in my tracks a few weeks ago when I read that. It was a piece of science done for Sage, these are people with symptoms who don't isolate. And don't get me started on Dominic Cummings, but that's where infections are going to come from. So getting the incentives right to encourage individuals and businesses, which is the next point, to do the right thing is really important. That's a national thing. I'm told it's being considered at the highest levels of the Treasury, which I presume it means on the Chancellor's desk. But it has to be done quickly, because if it doesn't matter for me, I can work from. I've been at home for the past 14 weeks. I can continue to be at home. But if I'm a self-employed bricklayer, then if that's the difference between continuing to work with a bit of a cough and some mild symptoms and then infecting others versus not having any income at all, that's just the wrong set of incentives to give people. So and ditto support to the business sector. So the two businesses that had significant outbreaks in, one of them effectively closed for a fortnight, and that wasn't good. But to his credit, he did the right thing. But getting the support to businesses is critical. And again, it's a Treasury issue. I'm told it's being considered, and I'd like to see the answer. Face coverings. People think it's a panacea. It's not a panacea. Mine is here. There. They have an impact, no doubt about they have an impact. But they have an impact in context. The things that make a difference to reducing risk of transmission, in order, are staying at home if you've got symptoms, staying at home if you're a contact of a case, distance continues to matter, 2 meters, or whether it's 2 meters or 1 meters plus, or Lord only knows. Washing your hands, face coverings come last in that list. And then face coverings come with problems. If I have one on, I might touch my face a lot more often, and that becomes an infection risk, because that's how you get infected. You touch a surface, the surface has virus on it, you touch your face, you're infected. So we need to be careful on face coverings, because they're not the panacea that everyone thinks they are. And lastly, parochially for me, standing up an operational response for a long time, and we're not in complete control over all of it by a long stretch. So some tricky stuff. And lastly, winter. Those of you that watch Game of Thrones, winter is coming, and winter will be massively problematic, because coronaviruses tend to be seasonal, tend to have a higher impact in winter, and then you combine that with flu, and we're in a world of difficulty there. So this emerged in March in England, so we're over winter then. So none of us quite know what will happen in winter, so that will be problematic. So I think I've droned on for probably longer than my welcome, but I'll stop there and see what questions people have. Is that all right?
Fantastic. Thank you so much. It's so informative. I've got a couple of questions in the chat box just with regards to the presentation. So Anthony was just asking, on the slides, what's the difference between Pillar 1 and Pillar 2 data?
That one's easy. So then, well, no, it's not easy. So there are 4 main strands to the national testing strategy. Strand 4 is antibody testing, and I won't talk about that, because antibody testing is not fit for purpose beyond epidemiology and surveillance yet. And strand 3 is the Office of National Statistics weekly epidemiology report that they do. And if you really want to get a handle on what's happening in epidemiology, read the ONS stuff. If I get 5 minutes during the course of this chat, I'll put it on the website. Otherwise, I'll just send it to you, Lou, and circulate it. So they're known as pillars. Pillar 4, Pillar 3. Pillar 1 is the mechanism whereby we use the local lab, so Sheffield Teaching Hospital's public health lab, to test for coronavirus in those that are poorly enough to be hospitalised, and the NHS and social care also use that lab to test NHS and social care staff, and that's from the perspective of business continuity, to rule in or rule out COVID-19, and if it's ruled out, get them back to work quickly, and if it's ruled in, tell them to be off. An interesting side note, many of you will have picked up that Sheffield was a hot spot early on in the course of the pandemic. It was never a hotspot. The reason it was perceived to be a hotspot is because Sheffield Teaching Hospitals did the right thing for health and social care workers in order to kind of maximise business continuity, and tested its staff, wider NHS staff and social care staff, really quickly, really aggressively. And if you look, you're going to find, so all of that went through Pillar 1, where everyone else was only testing hospitalised patients. We were testing hospitalised patients and our staff who weren't poorly enough to be in hospital. So that's Pillar 1. Pillar 2 is everybody else. So if I develop symptoms tomorrow, I'm going to either go to the drive-through site that's near me. I live in Leeds, so it's in South Leeds, or I'm going to arrange for a home testing kit to be sent to me. I'll take the swab. Someone will shove this thing up my nose, tickle my brain with it. That will be then packaged up and sent off to what are known as the Lighthouse Labs, which are giant private sector labs run by Randox, which is a private sector lab company in Milton Keynes or Glasgow or Manchester. And that result's processed there, and the result comes back to me. That's Pillar 2. So Pillar 2 is everybody, and it's much, much higher volume, but it didn't come on stream till much later on. So early in the epidemic, as the slide shows, we were heavily relying on Pillar 1. Now we're mainly Pillar 2. But it's Pillar 1 and Pillar 2 together, which give you the total number of people infected. And then, they're all rolling in now.
No, thank you. The next question I had was from Tim. What are the factors for people choosing not to self-isolate, and is there a case of people getting more than SSP?
Genuinely, nobody knows, but my sense is, just from kind of conversations I've had with people, it's economic. I can't afford to be at home for a fortnight, or my symptoms are so mild that I'll be right, I'll be okay. But in the main, it's economic, and there's definitely a case for something more than SSP, because SSP is not great. I've got a family of 5 to feed. I'm not going to be able to feed them very well on statutory sick pay. So my sense is economic, and that's why consistently mine and others ask of the Treasury is that's the most important thing they need to sort out, please, because we can't sort that out locally. That does require national intervention. So, but I don't know that. That's just my kind of summation from what I've read and heard. I've never seen a single killer piece of research that sets that one out.
Thank you. Kylie's question, given that government guidance is rather conflicting, where else can businesses obtain good guidance?
Well, we've tried our best. I don't know whether we've done well enough. You'll tell us whether we've done well enough or not. We've tried our best. I've personally not actually got that far into the guidance. There's a specific guidance for the business sector. I know others have. Interesting aside in that I think I have been told by my legal department, or by the council's legal department, that we can't and shouldn't get into the business of writing local guidance, and I agree with that, because the more times we get into that space, the more we'll mess it up. But there isn't a single place where you can go to for the definitive answer. One thing I will say is that the government guidance is full of holes and difficult inconsistencies. To be fair to the people that write it, it's quite difficult. One of my kind of learnings from it all is to strip all the complexity out and go back to the basics. We know how the virus spreads. It's not airborne. We think, well, almost certain it's not airborne, but there's a bit of worrisome science that it might be. But we think it's not airborne. It's spread by, I have symptoms, I cough, the droplets land on something, I put my hands on something and I put that to my mouth. So that's one route. We know the things that can reduce the likelihood of infection: distance, hand washing, isolation if you've got symptoms, getting a test early. So all that kind of, there is merit. This is sort of a public health, narrowly defined public health answer, as opposed to something much broader. So there is something about stripping out the complexity and going back to the basics. But sadly, Tim, there isn't a single place to get a single definitive piece of guidance other than the gov.uk website, which, as I say, has its issues and problems.
That's why I follow you on Twitter, Greg. So Marie's question, is there evidence to support that face coverings, I just had another question, so I nudged it down, that face coverings can further reduce transmissions in the workplace, even if 2 metre social distancing can be maintained? Should we be looking to encourage this as a workplace in a workplace?
I wouldn't personally. So I'd use face coverings in the context of crowded, and there's a moot point about what crowded is. Crowded indoor public spaces, particularly where you're coming across people that you don't normally come across. But face coverings reduce transmission a bit, but if distance is maintained, they probably don't add a huge amount. And as I say, they come with problems as well. In that you put them on and off your face quite regularly. You see people with them. How many times have you walked up and down the high street and seen people with them hanging off their chin? That's a harbour for all sorts of respiratory bugs. They're pointless in that context. I'm not personally convinced of the merit of making them mandatory in all indoor public spaces. I'm not hugely convinced of the merit of making them mandatory in shops, but I can see it and I have some sympathy with it. But personally, I think it's a space that we've just got to tread carefully in, and there are other things that we can and should do that are far more impactful. As I say, I don't think that they're the panacea that we all want them to be. I could be wrong. I'm not the global expert on this, and it is fair to say that look to what happens in Southeast Asia. Face coverings are much more common. So I'm keeping an open mind on it. But I think yes, they make a difference, but I don't think they make a difference I don't think they make as much of a difference as we want them to do. And there can be a really easy argument to make that they actually do more harm than good as well. If you misuse them, if you think you're invincible, you get close to people, you don't wash your hands as often, all of that kind of stuff can increase risk of transmission, never mind decrease it. So they come with downsides too.
Thank you. Andrew's question, if you pick up a common cold in the autumn, are you at greater risk of being susceptible to COVID?
No. COVID-19 is a virus. If you pick up a common cold, you'll have a common cold. If you pick up COVID-19, you'll have COVID-19. I don't think that one leads to greater susceptibility to the other. One virus is common cold is a coronavirus, but it's a different type of coronavirus. To SARS-CoV-2 is the technical. COVID-19 is the illness. The virus is SARS-CoV-2. And they're different viruses. So, and I don't think there's a link between susceptibility for one to the other.
Thank you. Ian's question, will flu jabs be available to all to reduce other flu symptoms?
Yeah, so we're going to have a huge effort on flu jabs this year. So as I say, winter is coming. Flu is one of the defining features of winter. Interestingly, look at what's happening in the Southern Hemisphere. Australia is usually the good proxy for what's happening, what happens in their winter, which then translates to our summer. The hospitalisation rates for flu in Australia have flatlined. There's a virologist for the Twitterati amongst you, there's a virologist on Twitter called Ian McKay, who I'd heavily, if you want to get into this, heavily recommend you follow him. He does a sort of running commentary on flu in the Southern Hemisphere winter. Hospitalizations have flatlined for a number of reasons. One, because there's vaccination program in place, but two, there's huge emphasis on distance and hand hygiene, respiratory hygiene, you catch it, bin it, kill it type of messages. But we're still worried about winter. So there's going to be a massive impetus on flu vaccination this year. The priority cohorts for flu vaccination are always in this order. The elderly over 75s are far more susceptible to the severe impacts of flu. I had flu a few years ago. It was flipping awful. I'd never want to go back there. But if I'm 85, I'm going to have a really, really bad dose. So the elderly are always top priority because the clinical impact on them is greatest. Then those adults with a long-term condition and pregnant women. And again, we kind of focus on those with severe long-term conditions versus less severe. So end-stage COPD is much worse than fairly new onset diabetes, for instance. So we focus our campaigns in that space. So for the adult population, we focus on the elderly, those with a long-term condition, and those who are pregnant. And that's about reducing the clinical impact on the individuals affected, and then kids. So kids have mild flu by and large, but the reason we vaccinate kids is because they're spreaders. Anyone got kids? You know what they do? They do this, and they never wash their hands, and then they go and touch everybody else. That's a perfect way to spread flu. So we focus on vaccinating kids to reduce the transmission likelihood. But then pharmacists So that's the sort of the NHS campaign, which runs time immemorial, and we'll be pushing it really hard this year. But then pharmacists and lots of employers also do occupational schemes. My own employer does. And I frequently encourage people to go and get their pharmacy. So I'm not in any of the at-risk groups, but I always go and get my flu jab done every year. Just pay my pharmacist, I think it's a tenner or something like that, and get vaccinated. And I've learned to my cost that flu's not a very, very nice illness a few years ago. So I've had my flu jab diligently every year. So the NHS campaign will be focused on the spreaders and the at-risk group, but there's always the opportunity to get flu jab for anyone else that's not in those groups, and we'll be pushing it hard this year for obvious reasons.
Thank you. If it's all right with you, Greg, we're going to stay on this coronavirus because we've got so many.
Yeah, keep it going. Keep it going.
We can arrange another session for general public health. So I've got a couple of lockdown questions, so I'll try and merge those together. So Dale's question: 3 weeks late on lockdown, in your opinion, what impact would it have if we locked down earlier? And John's question: if there is a local lockdown, what are plans in place?
So the 3 weeks late, I think it was 3 weeks late. This is a question for the inquiry. I wouldn't prejudge an inquiry now, but I remember there were lots of calls on me at that time. We're going to lock down Sheffield. And whilst I may have agreed, I didn't have the power to do it. It was a national thing. The powers to do the things that we eventually did rested with government. So much as I can whine and vacillate about it all I like, didn't have the power or legal authority to do it. I remember at the time, and I must dig out my memory on this one, but there was a sort of a graded approach to increasing the severity of the message and the interventions. You'll remember sort of early March, Boris was up in front of the lectern. And so, this is looking quite serious. I think we should wash our hands more frequently, etc. And then those messages got rather more serious. But we all ignored it. Boris's first serious statement was just before, I forget, it might have been Easter, I can't remember. No, it was before Easter. But we all ignored it. We all went to Snowdonia that weekend or somewhere. So it wasn't until he got really, really serious that eventually we did lock down. But in the meantime, what was perfectly obvious was that there were lots of people coming back from their half-term skiing holiday from Lombardy, which was a very, very, very high incidence area at that time. That brought back lots of infection, which seeded infections across the whole of society. And 500,000 people went to Ascot from all over the country. 500,000 people went to watch the European Cup final or whatever it was. So that was a time of exponential growth, but we just didn't know it at that time. So hindsight's a really, really easy thing to say. But with hindsight, I think we should have locked down 3 weeks earlier. Neil Ferguson, the imperial epidemiologist who wrote the modelling stuff, he subsequently got caught breaking the rules and had to resign in some disgrace. But his modelling was very, very influential, and it was his modelling that said 500,000 people are going to die here. That was what caused the sudden change in heart. But it was just a few weeks too late. And as Neil later said to the Public Accounts Committee, had we done the lockdown 2 or 3 weeks earlier, you'd have missed 3 weeks of exponential growth, and we'd be in a position where there are half as many deaths and half as much impact. I still think we would have locked down, however, but we would have avoided a lot of the death and misery that went with it. So those are questions for an inquiry, to be brutally honest. And I'm not going to prejudge it, but I think the general consensus in my community that we did lock down a wee bit too late. So then, is there a lockdown in Sheffield? No. The government haven't been terribly clear about the precise threshold for lockdown, but it's generally thought to be 50 cases per 100,000 per week. So that's the kind of the absolute threshold. Remind you that Sheffield is hovers between about 10 and 11 cases per 100,000 per week, there or thereabouts. So as I say, it's a bit high. And it needs to come down. The other things that matter are is that incident rate going up? If so, how quickly? Or is it going down? And are there how many incidents and of what nature are they? So if there's 3 outbreaks that are in relatively small institutions, one care home, one workplace, one somewhere else, all well managed, all well contained, no one will worry too much about that. But if you get to a scenario where you have had in Leicester, you have in Blackburn and Darwen now, where there's fairly widespread community transmission, that's much more worrisome, because that's much more difficult to control. So those are the kinds of criterion for a lockdown. We're nowhere near that. We were identified as having we were identified as an area of concern a few weeks ago. It was a tough call to take, but we took it, and it was a reflection of the fact that rates were just a bit too high for comfort. But we're nowhere near lockdown, to be honest, and numbers are going in the right direction, if a bit too slowly. So quite what lockdown looks like, look to Leicester, which has had a fairly severe version of lockdown, and look to Blackburn and Darwen, which is a fairly mild version of lockdown, where I don't think we've got into the business of closing down businesses again. I think it's much more soft than that. But although no one wants to go back there, we think it would be bad, wrong. You'd be damaging in all sorts of ways. So it's up to all of us to try and avoid it, I guess. You're on mute, Louise.
I am on mute. A couple of questions with regards to just reopening. So John and Anthony just asking, if kids are super spreaders, are we supportive of them going back in September? And are you supportive of the decision to allow spectators to the Crucible to watch the snooker?
I knew somebody had asked the bloody snooker question. Jack, I'll do the kids one first. We don't know that. So kids are super spreaders of flu. We don't know that they're super spreaders of COVID-19. In fact, the indications are that they're probably not super spreaders of COVID-19. We don't think kids will have this illness, no doubts about that. When they have the illness, it'll be fairly mild, and we're not testing kids a great deal, but all of the epidemiology that's done tends to suggest that children aren't infected at any greater rate than adults. All up, I think the rates of infection are low enough to kind of reopen schools, but the schools are going to have to operate in a COVID secure way, whatever that actually means. It's really difficult. If you want the distance between kids that we really want, the school estate is going to have to be 4 times bigger than it is. So there's a whole bunch of three-dimensional puzzles that are going on at the moment, trying to put all of that together, but all up, I think the rates of infection are low enough now, and we've got a good handle on how to manage incidents as and when they happen to enable that to be as safe as it can be. And the other thing that is in the mix is that kids not being at school does harm, stunts life chances. So school is good for kids, education is good for kids. We all know that. So yeah, balancing all of that together is kind of in the calculus. But it's impossible to say what September will bring. So a month and a half away from now. So our hope, and we're working hard to achieve that hope, is that rates continue to go down. So we'll be in a stronger position by September than we are now. Mine and lots of other teams are working hard on that one. Snooker. It's not my decision. It's World Snooker run World Snooker. And they World Snooker run World Snooker at the Crucible, and they're running it under DCMS, Department of Culture, Media and Sport guidance. So DCMS have indicated that they want to run a small number of test events in elite sport. Snooker is one of them. I did know what the others are. I can't quite remember what they are offhand. There's a moot point as to whether snooker is an elite sport or not. I don't know. You can draw your own conclusions on that one. So the World Snooker want to run the snooker in our town under DCMS guidance. The DCMS guidance is pretty good, actually. And we ain't going to be cramming 900 people into the Crucible. I think all up there will be about 100 or so, well distanced, well spaced, and they probably will have face coverings on, screening at the door. They'll be operating in a COVID secure environment, and it's up to all of us to make sure that actually happens. So the guidance is pretty good. Deputy Chief Medical Officer has been all over it. he trumps me. He's much cleverer than me. And if he's satisfied that the guidance on how to run it is a good thing, then so be it. I probably, or had it been my decision, I'd probably have gone there as well. There's some difficult mixed messaging that needs to be managed. We've been an area of concern. I think we won't be as of today, but we're still, rates are a bit high for comfort, as I've said. But equally now, it's okay for 100 people to go and watch the snooker for a fortnight. To come from all over the country, maybe all over the world, coming from all over the world, they'll have to be quarantined. So there's some really difficult mixed messaging. But equally, we can go to the pub now, and there's probably more risk in going to the pub than there is the snooker, because there's all of the booze you drink at the pub, which tends to impede our social distancing. And we've got to reopen society sometime. So, as I say, it wasn't my decision. Had it have been, I'd have been really reluctant to do it, but I probably would have gone there. But it has been a decision that World Snooker and DCMS have taken between them, and we will work with World Snooker and DCMS and the Crucible to make it as safe as humanly possible, I think, is where I am on it.
Thank
I'm
you.
I'm trying not to be mealy-mouthed on it.
Yeah, no, thank you. I want to just make sure we get Jay's question in. Is there any clarity on the link between ethnicity and getting COVID? Are you more likely to get it or have more severe symptoms because of your ethnicity, or is it a lifestyle issue, closer communities, families living together, faith gatherings, etc., or do we just not know?
The latter. There's no genetics at play here. Completely no genetics at play here. There could be, but we just haven't found them yet. But lots of people have looked quite hard, and no one's yet found any issue to do with skin color and genetics per se. It's an issue of close-knit communities, densely packed housing, large gatherings, faith communities, and broader sort of socioeconomic inequality and all that kind of stuff. So rates of infection are higher, largely on account of those factors, and impact is higher. Rates of hospitalization, intensive care, admission, and death are higher, largely because of underlying diabetes, underlying other health conditions just tend to be higher in the Asian and Black and minority ethnic communities. But that's not really an issue of skin colour per se. It's a factor that's to do with all of the other stuff that goes in the background. So made through much more complicated headlines, sadly. So therefore, it doesn't get as much airtime, that one.
Thank you. And then Rachel's question, some scientists have suggested this could be the second wave. Could this be the case? What are the plans with increased antibody tests? And I also just wanted to ask, where and how can people get tested in Sheffield?
Antibody. So there could be a second wave. I think we're at the end of the first wave, but there could be a second wave. You've all seen what's happening in the States. The States never got to the end of wave one before they've kind of reopened their society. And the rates have just gone up and up and up there. So all of the preconditions are present for wave 2, wave 3, wave 4. I remind you of your history. More people died in the second wave of the 1918 flu than died in the first wave, because we're all a bit bored of all of that stringent lockdown after the first wave, and we all thought, stuff it, it'll be fine. So more people died in wave 2. So we do, our chief medical officer stares at my community regularly once a week, and he says, you need to tell everybody that this is, I'm staring at you, this is not all over by a long stretch. We're trying to avoid wave 2, but no one can guarantee it won't happen. I think in all likelihood it will happen. The question is how big, how severe, and when it happens. We're trying to avoid winter, because winter is deeply problematic from an NHS perspective. And obviously what we're really trying to avoid here is people dying because the NHS is overwhelmed. So it's up to all of us to kind of reflect on that one. Antibody testing basically isn't fit for prime time yet. So antibody, we are doing antibody testing, but only in the context of epidemiology and surveillance. So ONS, the Office of National Statistics, do antibody testing with Public Health England, sort of a random sample of people once a week get tested. And that is published by ONS once a week. If you're a dork, it is worth looking at. I am a dork and I do look at it regularly. But that's done in the context of it's kind of done in the context of population surveillance rather than sort of the clinical the clinical interpretation. Have I had it? So that's the antibody test is. Have I had this illness and developed antibodies to it? The test, whilst there is a test, there's a phlebotomy test which requires someone to draw blood, and there are point of care tests which are close to being approved, finger prick tests which are close to being approved but not quite approved yet. Which will give you a result, but the problem is that the infectious disease docs don't yet know how to interpret the result because we don't know enough about the long-term immune response. So, if you were to ask an infectious disease doc, what does this test mean? What does this test result mean, doc? They don't know. They don't know how to interpret the test result yet. So I am aware of various places that are selling point of care or finger prick tests for antibodies in various places in Sheffield, including some community pharmacies. I'm actively encouraging people to not use them. I did a short video on it, and I'll send it you afterwards. Just so you can get a sense of the science. Just so you can get a sense of the science on it. It's a bit. It's unclear or uncertain actually. Then where can I get a test? 3 options. GPs are beginning to offer tests, but it's early days. And I've been encouraging government to get GPs into the space where they can offer tests for a while now, and I think they're beginning to get listened to, thankfully. The main testing site is the drive-through out of Meadowhall. And we've got a mobile testing unit currently operating on the Olympic Legacy Park, which I think will be there for another week or 2, but it won't be there permanently. And then we're building 3 more permanent testing sites in the east of Sheffield. I don't think we've actually decided the precise sites yet. And home testing is increasingly becoming available as well. So the logistics of that are run by Amazon. I think they're run by Amazon. And if they're good at one thing, they're bloody good at logistics. So it should be reasonable. And I don't think you need to be an Amazon Prime member to get that test from Amazon. Again, I'll put on I'll email you later, Lou, how you get a test sorted. There's a fairly simple way of getting it sorted.
That's really helpful. Thank you. I'm really conscious of time, but while you've got us, I just wanted to ask, what can we, as the Chamber and the business community, do to help you keep the transmission rates low for the benefit?
So I think in all of yours, I'll give you an off the cuff, but I'll consider it properly later. But in all of your advocacy and lobbying, push the Treasury and BEIS really hard to sort out the financial incentives for businesses. The last thing we want is for a business to be financially incentivized to do the wrong thing, because that has implications for everybody else. And ditto employees. Particularly those who are low-paid employees. So as I say, I'm fine. I can work from home, but if I have to be on site, it'd be wrong to incentivize people to be at work when they really ought to be at work. So push Treasury and BEIS really, really hard on that one. Secondly, is kind of just think through what does COVID secure mean, and you've got to run businesses. Businesses are good for us all. So, but it's kind of getting the balance right between running a business in a different environment, because we despite what Boris tells us, we haven't beaten this virus. It hasn't gone away. We're going to have to learn to live with it for quite some considerable time to come. So working out how to effectively run the business in that context just needs some thought. And I can't do that from the town hall, because each of your businesses will be different. And I don't know the circumstances on the ground in each of your businesses. So there's probably something that we could do together around kind of working out how we, as I say, strip away the complexity of some of this stuff. To get to some of the core principles, I'll put some thought into it afterwards, rather than coming up with some off the cuff rubbish now.
Oh, that's brilliant. Well, thank you so much for your time today, Greg. From the comments, everybody's just incredibly grateful to you for being honest and straight talking, and letting us know what we need to know. It would be great if we can get you back at some point in the future to talk more generally about public health.
Yeah, more than happy to either do a repeat of this or to do whatever you want. I'm at home. I'm locked up at home, so just whenever you want.
Fantastic. Well, yeah, I just want to say we're incredibly grateful. Thank you ever so much, and thank you for joining us. And I'll just draw that to a conclusion, and we'll look forward to seeing you again. Thank you.
Thanks all. See you in a bit.
Bye-bye.
Bye.